Good evening, everybody. My name is Mahmoud Hassanin. I'm professor of cardiology at Alexandria University. Let me introduce the first speaker, Professor Shelley Zieroth. She is the president of the Canadian Heart Failure Society and director of SBH Heart Failure and Transplant Clinics, head of Medical Heart Failure Program, WRHE in Cardiac Sciences Program. Professor Zieroth will address the topic of SGLT2 inhibitors and the cardiorenal benefits. Dr. Shelley? Yeah.
Great. I hope you can all hear me.
We can't hear you.
Okay, you can or you can't hear me?
Okay, yeah.
Okay, great. So thank you very much for the invitation to speak today. I'm here in the middle of Canada right now, where it is minus 20 degrees Celsius. So I really wish I could be there in person, and perhaps next year we should be so lucky to be together. So these are my disclosures, and I'm looking forward to speaking to you about the cardiorenal benefits of SGLT2 inhibitors. So in order to do that, I'm going to walk you through my journey with SGLT2 inhibitors. Why is a heart failure cardiologist talking about drugs that are traditionally recognized as anti-hyperglycemic agents? Well, this is where the story started for me. This is with the cardiovascular outcome trials in patients with type 2 diabetes. First came the HephREF trial, which randomized patients to empagliflozin versus placebo. And this patient population had type 2 diabetes, and 100% of them had established cardiovascular or peripheral vascular disease. Next came the CANVAS trial, which randomized patients with type 2 diabetes to canagliflozin versus placebo. And in this trial, there was actually about a third of patients that had primary prevention or multiple risk factors. And then next came the DECLARE TIMI 58 trial, which randomized patients to dapagliflozin versus placebo. And this one had the highest percentage of patients with primary prevention or multiple risk factors. And one more thing you should know about these studies is that only 10 to 15% of patients within these trials had a diagnosis of heart failure. We don't know much about that diagnosis, but they had a pre-existing condition of heart failure, so not many at all. And here's some of these trial results. So in the HephREF outcome trial, there was an impressive and statistically significant 14% reduction in MACE, a significant reduction in cardiovascular death, a 32% reduction in all-cause mortality, and here's what caught my attention, an unexpected 35% reduction in risk for hospitalization for heart failure, and as an added bonus, a significant reduction in renal events, including new or worsening nephropathy. Okay, so this is type 2 diabetes with established cardiovascular disease. Next came the CANVAS trial, looking at canagliflozin, another 14% reduction in MACE, another 33% reduction in heart failure hospitalization. The renal outcomes, we were seeing the same thing. And here's an unexpected finding. There was an increase in fractures, but then there was also a 97% increase in lower extremity amputations seen in this trial. However, no other SGLT2 trials demonstrated this finding. And in fact, the CREDENCE trial, which randomized patients with diabetic kidney disease to canagliflozin versus placebo, did not demonstrate this finding. And as a result of the CREDENCE trial and the pool of safety data from the other SGLT2 trials, the black box warning with regards to amputations from the FDA has been removed for canagliflozin. So let's move on to the DECLARE TIMI 58 trial, which again, this had the highest percentage of primary prevention or multiple risk factors. Now, because it was a lower risk population, it did not meet statistical significance for reduction in MACE, but it did have a significant reduction in cardiovascular death or heart failure hospitalizations. And again, the same signal for renal benefits when patients with type 2 diabetes received these drugs. So where did that leave us after these 3 trials? Oh, and I just want to point out one more point here, since this is a heart failure conference. The hospitalization for heart failure endpoint favored use of SGLT2s when patients had cardiovascular disease, as well as when they just had multiple risk factors. You see consistency of benefit with treatment with SGLT2 inhibitors across this patient profile for reduction in hospitalization for heart failure. So this figure nicely summarizes the cardiovascular outcome trials. In patients with established cardiovascular disease, there was a significant reduction in MACE with SGLT2 inhibitor use in patients with type 2 diabetes. And across the spectrum of risk, both in those with secondary prevention, as well as those with primary prevention and just multiple risk factors, we saw that impressive signal for reduction in hospitalization for heart failure. And we also saw that renal protective effect across the spectrum of risk. So let's focus a little bit more now on the kidney story. This is an infographic from the Credence trial, which I just mentioned at the time of the Canvas trial as well. So the Credence trial randomized patients to Canagliflozin versus placebo in the setting of diabetic kidney disease with albuminuria. You can see they had a reduced eGFR. So this was a kidney study. So the primary outcome, of course, was a renal outcome. And you can see patients randomized to Canagliflozin had a 30% reduction in the doubling of serum creatinine, end-stage kidney disease, or death due to cardiovascular or kidney disease. And here was an impressive reduction in need for dialysis. And again, in the Credence trial, there was no increased risk of amputations or fractures. So this is diabetic kidney disease with albuminuria, a significant findings for renal outcomes. But there were also significant cardiovascular benefits in these patients with diabetic kidney disease. You can see significant reductions in cardiovascular death or hospitalization for heart failure, CV death, MI, or stroke. And here, of course, is my favorite. Hospitalization for heart failure was significantly reduced in these individuals with diabetic kidney disease when they received Canagliflozin. Well, let's move on to the DAPA-CKD trial, which randomized patients to dapagliflozin versus placebo, right here. And now this was a little different in that these patients had chronic kidney disease, but with and without type 2 diabetes, unlike the Credence trial. And these patients also had some albuminuria as well. What we saw was, again, the significant improvements in the renal outcomes, renal or cardiovascular death, decline in eGFR. Again, another renal outcome was significantly improved. But again, we saw those cardiovascular benefits in patients with chronic kidney disease, reductions in cardiovascular death or hospitalization for heart failure, and of course, all-cause mortality as well. So pretty impressive findings. Furthermore, this post hoc analysis from DAPA-CKD demonstrated that the first heart failure hospitalization or the risk of first heart failure hospitalization was significantly reduced with use of dapagliflozin in this patient population, both in patients with established cardiovascular disease and without cardiovascular disease. So both renal benefits and cardiac benefits in this patient population. So far we've tackled Credence, which was canagliflozin versus placebo in patients with diabetic kidney disease, showing renal and cardiac benefits. Then DAPA-CKD, which was what we call chronic kidney disease with or without diabetes. Again, both renal and cardiac benefits. And we're still waiting for EMPA-Kidney trial, which will also, very similar to DAPA-CKD, enroll patients both with or without diabetes. I just wanted to share with you this interesting image that cardiologists are starting to get to know. And this is from our friends, the nephrologists. This is the KDIGO heat map. And what it does is it identifies the kidney risk of an individual patient based on the absence or presence of albuminuria, as well as the progressive reduction in eGFR. You can see that the cardiovascular outcome trials that I started with, EMPA-REG, CANVAS, and DECLARE, were a lower kidney risk population. And what we see with the Credence trial is a higher risk population identified by the green outline. And then, of course, DAPA-CKD as well, a similar profile in terms of increased kidney risk. So let's turn our attention now to HephREF and a little bit on the kidney as well. Remember back in 2019 when we were all at the European Society of Cardiology and DAPA-HF was presented, which showed us that dapagliflozin in comparison to placebo in patients with symptomatic HephREF with an ejection fraction of less than 40%, those patients who received dapagliflozin had a significant reduction in their risk for cardiovascular death and heart failure hospitalization. The room was electric and we were all together and it was wonderful. And it added SGLT2 inhibitors to the concept of guideline-directed medical therapy for HephREF. And you'll be hearing more about that from Professor Fonarow. And of course, in 2020 came Emperor Reduced. That was virtual ESC, which added to the totality of evidence in support of SGLT2 inhibitors as a form of therapy for patients living with HephREF. So I'm just going to briefly tackle in a couple of slides the Emperor Reduced trial findings as presented by Milton Packer. And again, I mentioned that the primary endpoint was significantly reduced, in fact, by 25%. The first secondary endpoint of total first and recurrent heart failure hospitalizations was also significantly reduced. But what also was interesting is that we saw that the renal outcomes in HephREF patients were also improved, such that patients who received empagliflozin had a slower rate of decline in eGFR over time. And furthermore, there was a composite renal endpoint, which was reduced by about 50% in this patient population as well. So impressive cardiovascular and renal endpoints when using SGLT2s in a HephREF population. And there are some similarities and some differences between DAPA-HF and Emperor Reduced. The percentage of patients on sacubitril/valsartan, for instance, was higher in Emperor Reduced, reflecting increased uptake of this newer heart failure therapy. The natriuretic peptide levels were slightly higher in Emperor Reduced, and the mean ejection fraction was slightly lower in Emperor Reduced, and thus a slightly higher risk population manifesting as an increased annual placebo event rate in comparison to DAPA-HF. But these two tales or two trials really tell one story. And I'll show you a figure from a commentary by my colleague, Professor Verma, McGuire, and Casaboro. And it's this figure, which looks at dapagliflozin and Emperor Reduced side by side in terms of their endpoints. And you see that cardiovascular death or hospitalization for heart failure significantly reduced by 25%. First hospitalization for heart failure, again, almost mirror image, side by side, relative risk reductions in hospitalization for heart failure. There were some comments early on about cardiovascular death being significantly lowered in DAPA-HF, but it didn't meet statistical significance in Emperor reduced. Interestingly, though, if we go back in time to the cardiovascular outcome trials, the exact opposite was true. They both showed consistency of benefit for first hospitalization for heart failure and reducing that risk. However, patients who in the declared TIMI 58 who received dapagliflozin did not have a reduction in cardiovascular death, whereas in EMPA-REG, those patients who received empagliflozin did have a reduction in cardiovascular death. Thankfully, Professor Zieroth, simultaneous with the presentation of Emperor Reduced, published this meta-analysis with his colleagues showing that overall that there's treatment effects for first hospitalization for heart failure or cardiovascular death reduction favoring SGLT2s. That is also true for reductions in hospitalization for heart failure when we combine the two trials together. And again, the overall treatment effects on cardiovascular death when we pool the two trial data together suggest SGLT2 inhibitors reduce cardiovascular death. And of course, also all-cause mortality. So taken together, these concordant results of the two HephREF trials with SGLT2 inhibitors have established SGLT2 inhibitors as a new standard of care for patients with HephREF. And I'm sure Dr. Fonarow will be speaking more about this. I do want to bring your attention to some other important facts with regards to SGLT2 inhibitors, and it is this, that they have their treatment benefit in patients both with and without diabetes. And what's also important to recognize is the speed of onset of effect. And what we've seen in these SGLT2 inhibitor trials is, in fact, and it's been recently published for Emperor Reduced, as well as DAPA-HF, that treatment benefit in terms of reduction of clinical events occurs, in fact, at under 30 days. And here's data showing the same for DAPA-HF, and the same is true for sacubitril valsartan in the Paradigm-HF trial. So that rapid onset of action is important to recognize. Now, we don't just prescribe HephREF therapies to reduce clinical events. We also do it with the hopes that our patients will have an improved function and quality of life. And this is data from the EMPA-REG trial showing that patients who receive empagliflozin were more likely to have an improvement and less likely to have a deterioration in their functional class after only 4 weeks of therapy. And there's also data to support improvements in the Kansas City Cardiomyopathy Questionnaire with use of SGLT2 inhibitor drugs in patients with HephREF. I like to show this slide because it summarizes the broad spectrum of patient profiles and cardiovascular benefits that we see in the clinical trials to date. And in particular, straight across the board, reductions in hospitalizations for heart failure or the risk for hospitalization for heart failure. So the big finale now, well, that comes with a trial called Soloist Worsening Heart Failure that was presented at the American Heart Association in 2020, just in November, frankly. And what this trial looked at was a drug called Sodaglyphlosin, an SGLT2-1 and SGLT2 inhibitor. And they looked at patients with type 2 diabetes and started therapy on stable admitted heart failure patients or very soon, very rapidly after discharge. So an acute heart failure admission, starting sotagliflozin in patients with reduced ejection fraction, and preserved ejection fraction. So meaning it did not matter what their ejection fraction was. And this was the finding, a significant reduction in the primary endpoint in total cardiovascular death, hospitalization for heart failure, and urgent heart failure visit in favor of those patients who received Sodaglyphlosin during their hospital admission or rapidly after discharge. But what was even more exciting, what they showed at the American Heart Association, was this slide, which was the pooled analysis of patients from soloist worsening heart failure and the SCORED trial, which looked at patients with diabetic kidney disease and Sodaglyphlosin therapy. And they pooled all of the patients in these two trials that had preserved ejection fraction. And this may be a hint as to what we're going to see with SGLT2 inhibitors in use in HephREF patients, is a significant reduction in this post hoc analysis in the same primary endpoint in favor of Sodaglyphlosin. This may be a hint of what we're going to see when Emperor Preserved is presented at the European Society of Cardiology, with Deliver looking at dapagliflozin following thereafter. Well, this slide nicely shows the prevention of heart failure events with SGLT2 inhibitors across a spectrum of cardiorenal metabolic risk. And you can see that the numbers of needed to treat to reduce the risk of hospitalization for heart failure decrease as we move across the spectrum of risk, as do the numbers needed to treat as we move across the spectrum of clinical trials for the risk of cardiovascular death or hospitalization for heart failure. How do SGLT2 inhibitors work? Well, there's a lot of interesting investigations underway, including there are concepts of osmotic diuresis. There's data from EMPA-HEART and DAPA-LVH showing cardiovascular remodeling, at least in patients with type 2 diabetes. There's change in the metabolic function. Even erythropoietin has been hypothesized as playing a role. But nevertheless, these are complex interactions which we're just beginning to understand between the heart and the kidney. As a result of this complex interactions, there have been calls for interdisciplinary cardiology and nephrology teams to make sure that we are identifying and minimizing the residual risk in our patients with type 2 diabetes, with chronic kidney disease, as well as in patients with HephREF, and maybe very soon in patients with HephPEF. My second last slide here focuses on what I think is a very practical tool. This is using Canadian units because it is published and presented by the Canadian Heart Failure Society and is available on heartfailure.ca, a practical approach to SGLT2 inhibitors for treatment of cardiovascular disease, with some reminders for areas of caution in use of these drugs, and some special considerations, including counseling your patients regarding the risk of genital mycotic infections and the need for proper hygiene, advice to avoid using these drugs on days when there are dehydrating illnesses occurring, and to monitor for signs of volume depletion. Professor Fonarow will be discussing the concept of quadruple therapy and the fact that SGLT2 inhibitors are now part of quadruple therapy. And my last slide is a reminder of why SGLT2 inhibitors are in fact an ideal HephREF therapy to implement. They're easy to prescribe and easy to take. There are significant clinical benefits in your patients. There are meaningful improvements in quality of life and functional status, which are important to your patients. The benefits are rapid. Within 30 days, we're seeing benefits. These drugs are exceptionally well tolerated and safe. There's no blood pressure lowering, and in fact, it's protective on kidney function. Thank you very much for the opportunity to speak today, and I would be happy to take any questions.
Thank you, Jenny. I will start the question. Do you think this is, I know this, we are lucky to have this in our market now for heart failure. This is a class effect or individual effects of the drugs? We have only two studies for the heart failure patient. Yeah.
The totality of evidence is in fact support of a class effect for SGLT2 inhibitors at this time. I know that the American College of Cardiology guidelines, as well as the Canadian Cardiovascular Society guidelines, will be reflecting this, that both the Emperor-reduced and DAPA-HF trial data is supportive.
Good question.
Thank you very much for your excellent presentation. My question is, to what level of estimated GFR we cannot use SGLT2 inhibitors?
Right, so the DAPA-HF exclusion criteria was to 30, and Emperor reduced. In Canada, we have an approval to 25. And there are, of course, the kidney trials have a lower eGFR as well, but of course those are CKD patient populations. So I think what we're going to see is people perhaps pushing the boundaries, and of course recognizing that every country may have its very own cutoff for eGFR as well.
Dr. Shelley, will these agents maintain their, efficacious effects in when the GFR is so low, below 25 milliliter? Glucose-lowering effects and the cardiorenal benefits. The second question: do you think that inhibition of glucose transporter 2 in the GIT would add to the benefits of these agents?
So the first question with regards to
efficacy at low GFR, will they lower still the blood glucose and have their cardiorenal benefits?
So my understanding is that lower eGFRs, the glucose lowering benefits are reduced. And thus far, it seems as though the cardiovascular benefits are, in fact, maintained. So much so that some of our nephrologists actually maintain these drugs until the patient starts dialysis. And that may be an interesting patient population to test as well. And your second question, it was a little staticky on this end. I didn't quite catch it.
Yes. Okay.
Second question about inhibition of glucose, sodium glucose transporter 1 in the GIT. Will this add to the benefit of these class of drugs? Inhibition of both, both transporters 1 and 2.
Yeah, I have not seen a side-by-side comparison of an SGLT2 and an SGLT2 and 1 inhibitor. What I think it does do is causes a side effect, an additional side effect of diarrhea and GI issues. So the preference may in fact be for SGLT2 inhibitors alone.
Thank you, Professor Shelley, for this lecture. I would like to know if you have an idea about the mechanism of the reverse remodeling that happens during this treatment. We don't know exactly the mechanism. Do you have an idea a little bit why there is a good beneficial reverse remodeling in patients with heart failure?
Yeah, it's fascinating, isn't it? We do have some MRI data demonstrating remodeling decrease in fibrosis in patients with diabetic kidney disease. Or not diabetic kidney disease, pardon me, with type 2 diabetes, pardon me. And that's from DAPA-LVH as well as EMPA-HEART. How or if remodeling occurs to the same degree in patients without type 2 diabetes, it's unclear at this time. There are studies underway, but I can't really hypothesize on the mechanisms beyond that. I know there's a lot of research going on.
Yes, I just want to ask you, the last ACC consensus was putting SGL2 as a second line side by side with MRA and other lines like efavirenz and things. But we have data now that comprehensive rather than sequential therapy would be more beneficial to the patients. So in your opinion, what will be the position of SGL2? Will it be a first line therapy or will it remain after the ACE and beta blockers. What do you think the future will hold?
Well, I think Professor Fonera is going to show you a pretty provocative proposal for starting quadruple therapy. My own practice is, my preference is to have a RAS inhibitor, and that being sacubitril valsartan first line. So, you know, I think I don't know if we have as much data for a comprehensive approach. We have some post hoc analysis suggesting that the benefit to our patients is more substantial. There's been a shift in how we contemplate delivering guideline-directed medical therapy, such that we address multiple pathways at low doses at once and then up-titrate in order to give our patients maximal benefits. But in fact, there's not much in terms of clinical trial data to support this change in our paradigm. So the Canadian Cardiovascular Society guidelines come out with ARNI, beta blocker, MRA, and SGLT2 inhibitors all evenly on one level. The American College of Cardiology just published in early February their algorithm. They start off with ARNI and beta blocker as sort of first line, and then they add MRA, SGLT2 as sort of a second tier. So my preference, and perhaps it's just somewhat traditional, and really a lot of what we do is based on tradition and history and not based on biology whatsoever. But I would still put sacubitril valsartan probably on first with a beta blocker. Then I would add MRA and SGLT2 inhibitors. Dr. Fonero has a different proposal, but I think that there is an urgency to get patients on a little bit of all of these main four drugs, and then to consider other phenotypes like worsening heart failure. There's some other drugs like vericiguat and omecamtiv mecarbil that should be considered in various patient populations as well.
Yes, Dr. Atif.
Professor Shelley, in your real practice in HephREF patients, do you have a percentage of how many patients adhere to these new drugs?
Yeah, so great point. Adherence is an issue, and I would say in my practice, I suspect about 70% adhere, which would mean 30% do not adhere. And certainly as we add in more and more medications and the medications cost more, that adherence may fall down. Not only is there an issue with patient adherence to medical therapy, there's also an issue with physician inertia and not prescribing appropriate medical therapy. And I think that those are two big barriers in terms of optimizing therapy for our patients.
Do you have any data about the effect of the SGLT2 on the incidence of stroke?
I recall that, as a combined composite endpoint in the CKD trials, there was a reduction. I don't know the data for reduction in stroke as an individual endpoint offhand.
Okay, go.
Now we have two very beneficial molecules, the DABA and the EMBA. When you use DABA and when you use EMBA?
Sorry, I add on to these questions. There's a claim that EMPA has no mortality reduction, but it is included in the composite endpoint. That's why DAPA the first, EMPA the second. This is claiming, if you had put the two in the table. I'm adding to these questions. Do you have an answer for this?
Yeah, so I think Professor Zanad's meta-analysis really reassured, or should reassure everybody that when this data is pooled, that there is cardiovascular death reduction in patients with HephREF. And so as a result, the guidelines do not, at least the ACC and the Canadian guidelines, don't differentiate between these two agents in the use for HephREF. And in real life, I take turns, prescribe DAPA one patient, EMPA another.
Thank you very, very much for this very wonderful talk and interactive discussion. Thank you very much. Okay, thank you. Bye-bye.
Thank you for having me.